Good afternoon, and welcome to our lecture on subcutaneous immunoglobulin administration. My name is Brittany Isaacs, and I'm a graduate nursing student at the University of Maryland. Tonight we're going to talk about providing autonomy to our patients through the use of subcutaneous immunoglobulin therapy versus the traditional way of IVIG or IV immunoglobulin therapy, which is when they're tethered to a chair at an infusion center or in their home or in the hospital setting. So let's begin with our objectives. So we're going to move. So today, by the end of this presentation, as you can see, we're going to discuss the primary and autoimmune disease groups. We are then going to recognize examples of each primary and autoimmune. Then we will describe and explain the treatment modalities for each group. Then we'll define subcutaneous immunoglobulin. And finally, we will then demonstrate the steps needed to take to self-administer via sub-Q IG. So first, let's just review primary immune disease. So in primary immune disease, we have two types. We have primary, which is genetic, and then we have secondary, which is acquired. So in primary, as you see here, we get it from, we're born with it through a genetic mutation that comes from our parents, and the disease emerges. And then when you have the secondary primary immune deficiency, that's acquired. AIDS is a good example of an acquired immune deficiency. So our treatment modalities are similar for primary as they are for autoimmune. In both primary and secondary immune disease, we see patients that are more susceptible to infections such as pneumonia, sinus infections, skin infections, meningitis. And we have to remind those patients, their family and friends, that they are susceptible to infection and take the necessary precautions. And so if anyone is sick, they need to stay away. We have to use proper hand hygiene. And we do a lot of education with those patients. To increase their immunity, we give them immunoglobulin therapy. So then with autoimmune, that can happen at any time in a person's life. Their immune system starts attacking healthy cells, and they are still susceptible to infections similar to those in primary immune disease. We are not sure of the cause or why these things happen to patients, and we have roughly over 100 different rare diseases that fall under autoimmune. They are doing research and clinical trials every day. At Johns Hopkins, they're doing a lot of research on figuring out all of these diseases and ways to treat them with new blood tests and different types of biopsies to figure out what the disease is and how we can treat it. So this is just a little picture of symptoms of autoimmune disease. So we see muscle fatigue, infection, respiratory compromise. They're very similar in nature with the primary immune patients, but the diseases are vast and each one kind of has their own uniqueness about them, and we're going to just discuss that momentarily. So here we have some examples of primary and autoimmune diseases. So on the primary immune side, the common variable immune deficiency, that is a big disease that you see pretty prevalent in. Then the hyper IgG and IgM syndromes and the subclasses on the IgG. So they're a little different than the autoimmune. So in autoimmune, you have the chronic inflammatory demyelinating polyneuropathy, or CIDP as it's known in the environment. And then you have Guillain-Barré syndrome, GBS. A lot of times you'll see that with the flu vaccine, which then leads into CIDP. So those two disease groups are closely linked, and you'll see them on the foundation. Then you have myasthenia gravis, or MG, and then myositis, or dermatomyositis, and polymyositis. as well as inclusion body myositis fall into the myositis category. And they're both neuromuscular diseases. With myositis and MG, they're closely related. In these diseases, on the autoimmune side, we will see muscle fatigue, respiratory compromise. MG presents with a droopy eyelid and muscle fatigue and blurred vision. So you get the blurred vision, muscle fatigue, and then the droopy eye as a consequence of the muscle weakness. So then next, we have our treatments. So in both auto and primary immune disease, we are using immunoglobulin therapy. We're using that to boost their immunity and help them fight off infections and prevent their body from attacking themselves. So with primary and autoimmune, they work a little bit differently, but our main goal is to boost the immunity. So subcutaneous immunoglobulin just means that we're administering into the subcutaneous tissue, which is fatty tissue. With intravenous immunoglobulin, we're administering through an IV, a port, a PICC line, a central line, and that takes place in the patient's home, the hospital, or the clinic setting, whereas the subcutaneous immunoglobulin, we can actually administer patient-directed in their home, traveling, what have you, because they get to administer it themselves. So a nurse provides the teaching, and then the patient is then able to complete their own infusion at their leisure without a nurse present. So we're going to talk a little bit more about subcutaneous immunoglobulin. So as I discussed previously, what is subcutaneous immunoglobulin?
So is that where you're basically going right through the skin into the fat?
Yes.
And how's that benefit versus IV?
So it takes a little bit longer to absorb. So we're seeing about a 24-hour absorption rate versus IVIG, which goes right into the bloodstream. And in doing so, we prevent the side effects. So some of you may know with immunoglobulin therapy via IV, we have aseptic meningitis, nausea, vomiting, diarrhea, severe headache, stiff neck. The side effects are very significant in IVIG therapy. So with sub-Q, we are not seeing those same side effects because we're dispersing a small amount of IG weekly versus a lump sum of IG over 4 days in a month, if you will. Yes, sir.
Does that mean the body's actually filtering a little better?
Not really filtering as much as it is absorbing, and it's just taking a little bit longer for absorption. So thank you for your question. Again, so with subcutaneous administration, it's 1 to 2 days, or 1 to 2 times per week, every week, and it takes roughly about 15 minutes to 2 hours depending on the dose. Whereas with IVIG, it's anywhere from 1 to 5 days per month, and we're seeing roughly 4-hour infusion times and sometimes longer depending on how well the patient tolerates the infusion. So as you can see, the benefits for subcutaneous being that it's shorter, the side effects are less, and it's patient administered. It has a lot of benefit over the IVIG, but it is dependent upon the patient. Obviously, if they're non-compliant, they have a hard time with dexterity, they're not always going to be able to draw up the medication and administer themselves. So it really is dependent upon the patient, and we do have to be mindful of that when we're picking a treatment modality. So next we're going to talk about the steps to administer subcutaneous immunoglobulin. Here we have Hizentra, which is one of our products that is on the market today. It is a 20% concentration, so it is the least amount of fluid that can be administered under the subcutaneous tissue on the market. So our steps are always going to be review our orders and make sure we have the proper dose for the patient. We're doing our 5 R's, so right route, right patient, right dose, right time, right orders. So then we're going to gather our supplies. So in the picture here are the supplies needed. We have our pump, our syringe, our tubing, our needle to draw up, our journal, and our alcohol preps. So after we've gathered our supplies, we'll wash our hands and prepare our supplies. So to prepare them, we're going to inspect our IG, make sure it's within the expiration date, that there's no particulates floating around, that it's clear, and then we will then pop the top, clean with alcohol prep, and connect our vented spike to our syringe and draw up our IG. Once we've drawn up our IG, we will then connect the flow rate tubing, and then that will get connected to our administration set. Once it's connected to the administration set, we can do two ways of priming, if you will. So the traditional way is to prime the line that you do with IVIGs, normal saline, any type of product you're going to administer to a patient via IV. But in this case, we need a dry needle. And this is counterintuitive for any provider who primes lines. So we do not want the IVIG or the subcutaneous IG to reach the tip of the needle. The IG is, can cause irritation to the surface of the skin. So to prevent that, we use a technique called dry needling. The best way to do that is to not prime the line at all. That is the manufacturer's guidelines. So we can do priming, or we can leave it of the small amount of air in the line to administer to the patient. And then after that, we're going to clean the patient's sites and insert the needles. And once we insert the needles, we then cover them with the tegaderm, and they stay in for the duration of the infusion, which again lasts, depending on the patient's dose, roughly 2 hours. So that's all the supplies that you would need, and we are going to review them again here momentarily. So here we're going to just watch a short film on the entire process so that you understand what is going on. So again, they're cleaning their surface and washing their hands, and now they're going to inspect their medicine, prepare for draw lap, and they're connecting to their flow rate tubing, they're cleaning their site, and they're inserting the needle. And that is it. It's very easy to start, and it's very easy for the patient. So this video is just nice to see the whole process. And so then next I'm going to just do a quick case study here so we can put it all together. So we have a 32-year-old female who presents to the clinic with the chief complaint of double vision, blurred vision, and a droopy eyelid. What is her suspected diagnosis? Yes, sir.
Myasthenia gravis?
That's correct.
Oh.
So with myasthenia gravis, what would be an appropriate treatment for this patient?
IV or sub-Q?
Very good. So in this case, we would like to do which treatment modality? Would we like to do IVIG or sub-Q IG?
Sounds like sub-Q is easier.
Yes. So let's take a look at how we will administer sub-Q. So now we're going to do a quick demonstration. On the table here, we have all of the necessary products. So Brian, would you like to help with this? Would you like to review what we went over in class?
You're not going to stick me, right?
No, sir. So we'll start at this end of the table. So we have our orders here, so you can go ahead and review your orders.
20%, 100 milliliters.
Very good. And how many grams do you have on that order?
20.
Very good. And we have 20 grams here. So we'll go ahead and we'll inspect our IG. And we'll make sure that the expiration date's good. So we'll go ahead and we'll actually open this. And so we'll do our inspection.
Made in Switzerland?
Say again?
Made in Switzerland?
Okay, so then I want you to go ahead and do what we just demonstrated on the video. I'd like for you to go ahead and draw it up.
Really?
Yes.
Okay. Well, hands are washed, obviously. Area's clean.
So Brian's connecting the vented spike to the syringe, and the vented spike allows the air to escape once he pops the valve off here, because anytime you insert into a glass vial, you have to let the air out.
You want to break into this?
Sure. And so then we're going to connect our flow rate tubing. The flow rate tubing controls how fast we administer into the subcutaneous tissue. There are several options. This is what's called the F900. So this takes about 2 hours to administer 20 grams of IV, subcutaneous IG. So this infusion would take about 2 hours. All right, so then we'll unscrew the vented spike. It is a plastic needle, so do be careful. We do put it in the sharp spin. So we'll put that away. We'll connect our flow rate tubing. And here we have four administration site sets that will then get connected to the flow rate tubing. And then we get to pick our spots. So anywhere that there is fatty tissue, we can insert these needles. Preferably, the easier way is in the thighs or in the abdomen. Some patients can do the flank area as well as the back of the arms. So we would prep the site and we would take one of the needles. The wings just help for guidance. Cleanse the area and insert. Flatten the arms, and then we would cover with the tegaderm. Easy, right? What do you think, Brian?
Looks pretty easy.
So then this will help the patient. In this particular case with the myasthenia gravis, it will help with the double vision, it will help with the muscle fatigue, and it will help with the droopy eyelid. So the patient has success with treatment, and it is easy for them to administer. They can travel with this, and they get the autonomy of doing it themselves. So this is a great option for any patient with an auto or primary immune disease. So thank you, Brian, and thank you everyone for your time. I hope you enjoyed this lecture.